Hello and welcome to the AMCP podcast series, Listen Up, as we take a deep dive into the challenges, trends, and opportunities in managed care pharmacy. Follow the show's social hashtag at AMCP Listen Up, and to learn more about AMCP, visit amcp.org. I'm your host, Fred Goldstein. On this episode of the AMCP podcast series, Listen Up, my guest is Dr. Ruchi Gupta, Professor of Pediatrics and Medicine at Northwestern University, Feinberg School of Medicine, and the founding director of the Center for Food Allergy and Asthma Research. Welcome.
Thank you. Happy to be here.
It's a pleasure to have you on and discuss this topic, really fascinating one. Why don't we start? Give us a little bit of your background as well as the background on the Center for Food Allergy and Asthma Research.
Sure. So I'm Ruchi. I'm a pediatrician. I got my master's in public health and started conducting research at Northwestern about 20 years ago, and started in asthma and then moved quickly towards food allergy because of a family who had two young kids with food allergy. And 20 years ago, we knew very little about anything around food allergy except for there was this rise. So really got into studying the epidemiology, the public health impact, and then, many, many more things, which we'll talk about. The Center for Food Allergy and Asthma Research was started about 5 years ago, and it also focuses on, the whole atopic march, eczema, food allergies, asthma. And we have about 9 faculty and about 50 staff. And it's an amazing place where we really do look at public health disparities, prevention, treatments, and anything that impacts your daily life, policies, schools, work environments, etc. So,
wow, it's a broad area of cover there.
Yes.
So tell us a little bit about the difference between food allergies and food intolerance. We see those terms kind of thrown around a bit.
Yes, and that is a very important question because they're often confusing. Usually when people eat a food and have a reaction, they don't know exactly what it is. And there are big differences in all the different things it could be. So let's start with food allergies. Food allergies are immune mediated. So it's an IgE mediated reaction that happens in your body. So what's happening is your immune system is recognizing that food as an invader and it goes on attack. And so what that means is it produces, all these cytokines and releases things that can cause your body to do multiple things. For example, skin things we often think of as hives or itching, swelling. Often you hear throat closing, trouble breathing, GI things, vomiting. So really a constellation of symptoms that can involve any organ system. So that's food allergy. And food allergy can be very serious. It can go into anaphylaxis, which is a very rapid, progressive reaction and can lead to death, although it is rare. But that's why we take food allergies so seriously. Other food conditions are also very, very important. And you mentioned intolerances, and that's probably the most common type. And what that is usually your gut is having trouble digesting that food. And most times it's because you lack an enzyme. So the most common one worldwide is lactose intolerance, where when you drink milk, you will get bloating and cramping and sometimes diarrhea, but it's localized, right? You're missing an enzyme to break down. So that will not lead to this constellation of anaphylaxis. It will lead to localized reactions in your gut. But it's important to note because lactose intolerance, you can enjoy milk products if you take a pill, that gives you the enzyme, or get lactose-free things. So you don't have to be like someone with a milk allergy, food allergy, where, that could be life-threatening, and it's really, really important to avoid.
Mm-hmm. So I know of like peanut allergies. Everyone probably heard about that. The airplanes banned, et cetera, stopped serving them. How prevalent are various food allergies?
Yeah, so food allergies are getting very common. So about 8% of kids have a food allergy and about 10% of adults. So we used to think of it as just a childhood thing, but it's not. It really can impact all age groups. The top 9, we call them now, food allergens include, as you said, peanut, milk, tree nuts, egg, shellfish and finfish, wheat and soy, and the number 9 is sesame, and that's up and coming as a significant food allergy in the U.S.
And given that sort of prevalence, do we have data around the costs of these?
Yes. Food allergies are very expensive. Our old numbers, our last study we did on this was in 2013. And back then it was almost 25 billion in the US in a year. So it is very expensive. And a lot of that is coming out of the patient's family's pockets. So the most significant amount of that is out of pocket costs. And that is related to, things like special foods is a big one, because you have to get specific foods without the allergen, things like epinephrine, that they need to carry. But other big costs are parents having to leave their job or change jobs or getting fired from a job because of their child's food allergy and, lost opportunity costs like that. Because since food is a part of absolutely everything we do, it's really hard to not be worried every single day, especially when you have a young child with food allergies.
Absolutely. So this is something that people are thinking about all the time when they're living with it. And obviously it's a daily kind of lifestyle change. And then on top of that, you're adding in potential ER costs and hospitalizations and things like that.
Yes, absolutely.
So when you think about this you mentioned a little bit about the IgE and this, how does this work from a scientific perspective?
Yeah, it is. It's really interesting. And we're all trying to understand it because when you think about how quickly food allergies have, come to be a significant condition, now I always hear, and I believe it, when we were kids, nobody really talked about food allergies and there were no, peanut bans in school and everyone took a PB&J to school. And so you hear this all the time. Well, when I was a kid, this didn't exist. So what's happened in a generation? And we know genetics don't change that fast. And so what is it in the environment that's causing this incredible rise in food allergies? So we're really trying to understand that and the science behind it. It could be partially genetic. There is always a genetic component. And that comes from this group of conditions that go together. And we call that, atopy, or, some people have heard of the atopic march. And so that's like eczema or atopic derm, dry, red, itchy skin, and then environmental allergies, and then food allergies and asthma. So they all kind of go together. So if you have a history of one of those, then you have a higher chance of developing food allergies. But then what is the environmental turn on? And that is something so many researchers, including our lab, are looking at. And so some hypotheses are, we've become too clean. And what are we doing to our microbiome on our skin and our gut? And so some of those things are our gut microbiome. What's changed? Well, we have more C-sections, we have more antibiotics. And what is that doing to the good bacteria, in our gut that we're supposed to have? We use a lot of antibacterial cleansers. What is that doing to our skin? And how is that getting into our gut? So a lot of different hypotheses. I could go on, but we'll keep going.
Yeah, it's a fascinating issue to think about because, like you said, as a child, maybe a person here or there, but obviously it's grown considerably and become much more of a important topic for all of us to consider, whether it's the individuals or the payers, et cetera. What about treatments? What's out there now?
Yeah, so this is a really exciting time for food allergy because in the 20 years I've been studying it, we now have prevention, ways to prevent food allergy, and we have treatments. And it's just getting more and more. And I'm really, really thrilled that people are going to have options for treatments. They already do, and they're more in development. So what do we have currently for treatment? We have 2 FDA approved treatments. One is oral immunotherapy for peanut. And so what that means is you eat small amounts and increase the quantity of that, and your body slowly recognizes it and does not react to it. A lot of times people know this as, allergy shots, et cetera, where you get small amounts and slowly go up. So that's one FDA approved treatment. The other one that was just approved in February of this year is Xolair. It's omalizumab. It is a biologic. It's anti-IgE. So I said this is an IgE mediated. So it's an anti-IgE. So it stops that binding to stop that reaction. So with this new biologic now, it's a shot. You take it once or twice a month. You have to talk to your allergist. And with it, the studies show that it does offer protection up to a certain amount of the food. So it's not a cure. You can't eat the food freely, but it does protect you from those accidental reactions that are always so worrisome. So those are the two FDA approved treatments. There are other treatments that people are offering. For example, when we talk about immunotherapy, there's also a sublingual immunotherapy. So the same kind of thing through drops under your tongue. And then there is another company that's developing a epicutaneous immunotherapy. Same thing, small amounts of protein, but through your skin. So under your tongue, through your skin, orally, those are three of the big treatments underway right now.
And the treatment is broader than just peanuts. Is that right?
Yeah. Well, the immunotherapies are food specific. Right. The biologic omalizumab that we have now is not food specific. So that has been shown to work on multiple food allergies. And that's another big advantage because so many people, at least 40% in our study had documented multiple food allergies, but a lot of people, the numbers really range between 40 and 70% having multiple food allergies. So it does make it easier for them to be able to manage all of them at the same time.
Right. And as we think about this, and obviously throughout the healthcare system, we see huge disparities across the board for all sorts of issues, medical care issues. What about within food allergies? I can imagine, whether it's in a rural community or a disadvantaged community, access to some of these approaches or even the foods might be difficult.
We do see significant disparities in food allergy. And, one really important thing as we move forward with all the new prevention and all the new treatments and diagnostics is how do we make sure we don't increase those disparities? So the new treatments we have, how do we make sure that they're accessible by low-income families and that there is awareness and education out there and coverage for those? And that's a really critical point because disparities already exist. And if now disparities in treatment or disparities in prevention or even access to care start increasing, then we're going to really see that disparity gap expand.
Mm-hmm. And is this something where you really should be seeing a specialist or somebody much more informed around the care for this?
Yes. And I think that's one of the biggest challenges when it comes to disparities, because I work in a Medicaid clinic and often it's very difficult and challenging to get our patients into specialists. And for food allergies, it's really important to get to an allergist. And the allergist is the person who can prescribe these treatments. So making sure that they have access to getting to an allergist is critical. But sometimes the wait is very long, 6 months to a year. And two, a lot of allergists, only about half of allergists in the US take Medicaid. So there's only about 4,000 to 5,000 allergists and only half of them are taking Medicaid. So what happens to, all the low income population or even rural populations, and how do we bridge that gap? So, working with payers and Medicaid to figure out how to make that better. And then also using technology, like can we utilize things like telehealth, for a generalist to be able to talk to an allergist and make a plan for a patient. So I think we got to start thinking outside the box to reduce these disparities. But yes, that is one of the biggest issues is a lot of these treatments and a lot of these diagnoses for food allergy are made by an allergist and not necessarily by primary care.
Certainly. And you sort of touched upon it, but this whole issue of payers and how they should be looking at this, obviously it's something that's growing, prevalence is increasing. So we've got a problem out there and potentially, as you talked about, it could be life-threatening in some cases or expensive hospitalizations, et cetera. What should payers be thinking about when they look at this area now?
I'm hoping payers really take it seriously. I mean, it impacts 33 million Americans. So, and that means a lot of ER visits. We didn't really get into that, but about 20% of kids with food allergy are reporting going to the emergency room at least once in the past year, and 10% of adults. So it's a lot of ER visits. It's a lot of costs for multiple things, not only ED visits and hospitalizations, but physician visits and epinephrine and, all the things we talked about. So I would love it if payers, really got on board and helped us cover these treatments, which I think would make such an impact to the costs that are incurred by the medical system and out-of-pocket costs for these families. There's great new treatments coming in that I think will truly change the tide. In addition to prevention, like if we can just prevent it on the front end, then that would even be better. So really supporting, all aspects of food allergy. And then, of course, supporting the new diagnostics that are coming out. We've got some great new testings, but payers have to cover them for us to be able to use them so that people don't get misdiagnosed and labeled as food allergy if they don't have it.
Yeah, and I'm thinking with my population health hat on and some of my health plan work in the past is it's one thing to say, okay, we're going to do benefits for this medical care. We're going to allow for the testing. We're going to go ahead and cover these products that help individuals. And then I suddenly said, well, we're now expanding into providing food services, and food is medicine. So are we going to understand well enough the issue of this individual is allergic to XYZ, so we need to make sure that if we get food services to them, they have access to the stuff they need so they don't have that allergic reaction.
Yes. And that is a real big push we're trying to make. Like, how do we get safe foods to all these people, 33 million Americans? And we really realized it during COVID when, there was so much food insecurity too. And if you have food insecurity and you're only able to get certain types of food, then how do you stay safe? And what we've seen is low-income kids spend a lot less on special foods, a lot more on emergency department visits, and a lot less on allergist visits, and a lot less on epinephrine. But that biggest cost is ED visits. And so if they're going to the emergency room, that in itself could pay for all the other things.
Right. Absolutely. And you think about it as you talked about earlier, from an impact on the individual and the family. Yes. It's really a daily deal, and so every day it's kind of got to be in the back of your head. Here's what I'm trying to do. Here's how I'm trying to live my life safely, et cetera. So the impact could be profound from an economic perspective as well.
Oh, absolutely. I mean, I don't know if I mentioned, but I'm also the mother of a child with food allergies. So, I was studying food allergies for about 3 years, and then my daughter had her first reaction, and then I became a part of the community, and I've learned so much. And it is so true because it's part of everything kids do and adults. Food is everywhere, right? Like everywhere you go,
right?
There's food. And it's something, you definitely do at least 3 times a day. Kids do it even more, and every party or social event and gathering. So it's constantly on your mind. So if you had a treatment where you didn't worry as much that you were going to have an accidental ingestion, not only, does it help you with all the costs associated, but peace of mind, right? And stress and anxiety.
Yeah.
Which we know impact health so much,
Oh,
so.
Incredibly. Yeah. Well, that's fantastic. Well, I'd like to thank you so much. It's been a pleasure to have you on. Thank you, Ruchi.
Thank you so much for having me.
And thank you for joining us today. If you like this show, you can find all our episodes at amcp.org/podcast, on our show page at healthcarenowradio.com, or on your favorite listening platform by searching Healthcare Now Radio. You can follow our show's social hashtag at AMCPListenUp, and don't forget to share, like, and follow AMCP.org on LinkedIn, Twitter, Instagram, and Facebook. I'm Fred Goldstein for AMCP. Until next time.